The mammalian sympathetic nervous system is an incredibly efficient survival mechanism. When confronted with a physical threat, it triggers a sudden, explosive spike in adrenaline, accelerating heart rate and respiration to prepare the body to fight or flee. But in clinical psychology, we observe a severe pathology where this exact biological sequence triggers in a completely neutral environment. Panic disorder occurs when this intense physical arousal system completely decouples from any actual external threat. To understand this misfiring system, look at this case study, Michelle's story. She describes routines interrupted by panic attacks coming back with a vengeance. Her cognitive markers are highly specific. She is terrified of negative thoughts, fearing she might have a heart attack. These cognitive fears are driven by very real physiological markers. The patient experiences dizziness, palpitations, and chest pain, sensations that perfectly mimic a life-threatening cardiac event, despite the heart being perfectly healthy. Surviving these overwhelming physical sensations on a daily basis is exhausting. The chronic dread of the next attack often leads to extreme secondary symptoms, including severe depression and suicidal ideation. To effectively treat this condition, we have to deconstruct its biological roots, trace its epidemiological spread, and solve the clinical paradox of why providing immediate symptom relief often makes the disorder worse in the long term. Panic disorder operates as a self-sustaining loop. The body's own survival mechanism becomes the primary threat to the patient's existence. Psychologists map the origins of this condition using the diathesis stress model. This architecture dictates that panic disorder requires two distinct elements to emerge: a baseline vulnerability and an environmental catalyst. The baseline vulnerability is biological. In the clinical literature on genetic factors, twin studies confirm a moderate heritable component to the disorder. Researchers estimate that 30 to 34% of the liability to panic disorder is encoded directly in a person's genetics. This genetic substrate manifests psychologically as high neuroticism and behavioral inhibition. The baseline sensitivity is dialed up, waiting for a spark. That spark is the environmental catalyst. 80 to 90% of patients experience their first full-blown panic attack immediately following a severe negative life event. These stressors are typically acute, high-impact events: the loss of a loved one, a sudden job termination, or criminal victimization. Yet severe stress alone does not cause panic disorder in the general population. The catalyst only works if the 34% genetic vulnerability is already present in the patient's biology. The genetic predisposition acts as a loaded mechanism, while severe environmental stress provides the requisite force to pull the trigger. Once that trigger is pulled, the disorder distributes across the population in highly uneven ways. This epidemiological data from the World Mental Health Surveys tracks the association between gender and the lifetime risk of specific anxiety disorders. Look at the exact odds ratios for females. For both agoraphobia and panic disorder, the ratio sits at a stark 2.0. In practical terms, this means women are exactly twice as likely to be diagnosed with these conditions compared to men. Researchers attribute this discrepancy to a pronounced sociocultural variable. In many cultures, societal norms permit women to vocalize their fear, actively avoid frightening situations, or request a trusted companion to accompany them. By utilizing this socially acceptable avoidance, the patient briefly escaped the panic, but directly facilitates the development of comorbid agoraphobia, the intense fear of being in places where escape might be difficult. Men face a different sociocultural expectation. They are frequently pressured to tough it out and maintain an assertive, instrumental approach to life, regardless of internal terror. Because they cannot socially avoid the feared situations, men with panic disorder routinely turn to self-medication. They rely heavily on alcohol or nicotine to endure the physiological spikes, masking the underlying disorder. The biological trigger of a panic attack remains universal, but societal expectations dictate the resulting pathology, manifesting either as highly visible agoraphobic avoidance or hidden chemical addiction. In a clinical setting, panic disorder rarely exists in a vacuum. It acts as an anchor point for other severe pathologies. The statistical reality is grim. The vast majority of people with panic disorder, specifically 83%, will develop at least one comorbid condition. The most common associated condition is depression, affecting 50 to 70% of individuals experiencing serious panic disorder. This is a bidirectional relationship. The chronic fear forces patients into avoidant lifestyles, systematically stripping away positive reinforcement and breeding depressive states. This fear state also links directly to elevated rates of PTSD and severe substance use disorders. This matrix of comorbidity introduces the most severe clinical risk, a sharp, measurable increase in suicidal ideation and attempts among these patients. Crucially, large epidemiological studies reveal that this elevated risk for suicide is intrinsic to panic disorder itself. The risk remains high, independent of whether the patient has also developed comorbid depression. Clinical intervention requires dismantling this central nexus, as it serves as the fuel for a much broader psychological collapse. This presents a unique clinical dilemma. How do you treat a disorder where the patient's primary fear is their own internal nervous system? The most immediate pharmacological intervention involves prescribing fast-acting anxiolytics. These are typically in the benzodiazepine category, like alprazolam or clonazepam, which suppress the nervous system in 30 to 60 minutes. While effective in the acute moment, these drugs carry massive drawbacks. Prolonged use leads to extreme physiological dependence, impaired cognitive performance, and sedation. Worse, withdrawing from benzodiazepines causes nervousness, sleep disturbance, and dizziness. These withdrawal symptoms perfectly mimic the physiological sensations of a panic attack, practically guaranteeing a relapse. The most effective alternative is a specific form of cognitive behavioral therapy. It utilizes a technique called interoceptive exposure. As detailed in this clinical text, interoceptive exposure relies on a counterintuitive logic. Therapists deliberately force patients to experience the physical sensations they are terrified of, having them spin in a chair to induce dizziness or hyperventilate to induce a racing heart. This triggers a mechanism known as habituation. By repeatedly inducing the physical symptoms in a safe environment without a resulting catastrophe, the brain learns to break its cognitive misinterpretation loop. The alarm rings, but the mind stops assuming there is a fire. Logically, one might assume that combining fast-acting medication to ease the panic with CBT to fix the cognition would yield the best possible results. Clinical data reveals a paradox. Patients receiving combined treatment, medication plus CBT, actually show a greater likelihood of relapse once the medication is eventually tapered off. The failure comes down to psychological attribution. When a medicated patient survives an exposure exercise, they attribute their survival to the drug in their bloodstream, rather than their own cognitive resilience. In the treatment of panic disorder, providing an immediate chemical shield actively prevents the patient from building the cognitive armor required for long-term recovery. We can now map the complete architecture of this condition, from the initial biological vulnerability to the full clinical manifestation. The 34% genetic heritability is the unchangeable baseline, setting the resting tension of the nervous system. A severe environmental stressor acts as the initial spark, igniting the first decoupling of the fear response. But while biology and environment start the fire, it is the patient's own cognitive feedback loop, interpreting a racing heart as certain death, that sustains the disorder for years. Interoceptive exposure therapy works because it strikes at the exact weak point in this pathology, severing the link between physical sensation and catastrophic thought. Chemical suppression fails because it merely mutes the physical arousal temporarily, leaving the fatal cognitive misinterpretation perfectly intact for the next time the heart rate climbs. The fear response is an ancient, hardwired survival tool. You cannot simply turn it off. Patients achieve long-term recovery by retraining the mind to recognize these physiological alarms as harmless biological signals rather than existential threats.